of challenge number 2 in our mission, Health Equity Challenge Series. We'll start today's meeting with a presentation from Dr. Umut Gurkan, Professor, Department of Mechanical and Aerospace Engineering, CWRU School of Engineering, member, Cancer Prevention and Control and Population Research Program. Case, Comprehensive Cancer Center. Let's give everyone a minute or two more to log on. Okay, welcome again, everyone. If you haven't typed your name in the chat for attendance yet, please do so now. Without further ado, let's meet our presenter, Dr. Umut Gurkan. Dr. Gurkan is a professor in the Department of Mechanical and Aerospace Engineering, CWRU School of Engineering, member of the Cancer Prevention and Control of Population Research Program, Case Comprehensive Cancer Center. Dr. Gurkan's group works on gaining a fundamental understanding of hemoglobin, red blood cells, blood rheology, and microcirculation in health and disease, with targeted interventions and gene-based therapies. Dr. Gurkan's research has led to new biomedical microtechnologies that improve patients' access to timely diagnosis and personalized monitoring of emerging therapies. He has led multi-site international clinical testing of this technology in the US and in low and middle income countries worldwide. Dr. Gurkan received a CTSC Annual Pilot Award in 2014 to develop sickle cell disease blood assay technology, and in 2019 to translate a new personalized microfluidic diagnostic platform for gene therapies in sickle cell disease. Dr. Gurkan, you may begin.
Thank you, Zina. Thank you, Zina, for the nice introduction. And today I would like to talk about our research as it relates to the chapter 6 of this amazing book that we all read and learned a lot from. So I would like to talk about how we approach personalized medicine for all and how to develop and translate diagnostics, treatments, and cures with equity. And I will highlight certain aspects of our work as it relates to chapter 6. And I hope to have a nice discussion afterwards related to the topics that I will talk about. So in chapter 6, these 4 statements resonated with me and our research program the most. The first one is the author indicated that she learned a lot on how a low-income country with a strong focus on prevention and primary care could be successful at minimizing health equities. So this has been our approach for many years now. We would like to make the prevention of diseases and primary care as comprehensive as possible, even in the most resource scarce settings. The second statement was the local to global and global to local approach. And this approach actually involves understanding that solutions created in resource-poor contexts can also have the potential to improve care in resource-rich settings. And I will try to give some examples of how this can happen. And solutions created in resource-poor contexts also have the potential to improve care in resource-rich settings. So this is part of the local to global, global to local approach. And researchers and public health officials from resource-rich nations often feel they have all the answers. This is quite common, especially in our field of biomedical engineering. As an engineer, I see this a lot. Engineers and scientists think that they have the best solution or the best answer to a problem, which most of the time is not the case. But if they fail to listen to community leaders, they can learn what interventions could have the biggest impact. And I will also try to give some examples of these. Before I start, I would like to indicate my disclosures. These are the companies that I have started over the years and I'm still involved with. These companies range from point-of-care diagnostic device companies for blood disorders, malaria, anemia, beta thalassemia, sickle cell disease, which I will talk about today. Biochip Labs, another company located in Cleveland, focused on gene therapies, providing supportive technologies for gene therapies in the context of diagnostics. Another one is ClotChip Exatech. This is also a Cleveland-based company for bleeding disorders. And before I joined CASE, I was involved in starting a company in IVF, in vitro fertilization, and that company is also, still in the market with products, so I have to disclose these. So I'd like to start with a video that highlights our approach. Our approach is well integrated into the providing the interventions followed by diagnostics. And how can we make the diagnostics and interventions more accessible, more affordable, and more importantly, how can we have an more inclusive and equitable approach to developing new solutions to problems that impact populations in the global context as well as here in the United States.
If a child has sickle cell disease in Africa, only about 20% will see the sixth birthday. We know for a fact that 96% do not get tested. And those then grow up getting pneumonias, sepsis. If they have the dual gene, they are actually more susceptible to malaria and die from malaria. The human toll is unimaginable.
There are definitely countries in Africa where 25% of all child mortality is being caused by sickle cell disease. And if you can diagnose them, 70% of those kids would live. And if they're not diagnosed, more than half die by their 5th birthday. So, we're talking 750 kids a day are dying from sickle cell disease.
Those 15,000 newborns every year come with sickle cell disease. For us, and for sickle cell disease patients, the first entry point is newborn screening.
The traditional diagnostic using HPLC or these larger machines are only located in the big centers. So, for example, in Ghana, you only find it in Accra and Kumasi. We would have to transport the baby and the mother, take a bus, take them to the city center, wait for a day or two to get the results, and then transport them back. So having the point of care diagnostic is going to revolutionize the number of patients we can screen and diagnose, and therefore treat, and therefore keep alive.
So I'm Patty White, and I'm the CEO and co-founder of Hemix Health from Portland, Oregon. Our product has a 1-minute malaria diagnostic and an accessible, affordable sickle cell diagnostic. So we really create this platform, this lab in a box that can really go out and do tests and make these tests be affordable and easy to use.
Truly transformation. They can live a normal life into their 50s and 60s. Just a simple diagnosis, penicillin, hydroxyurea, and a pneumococcal vaccine that could transform the lives of millions of patients in Africa and South America and Asia. It's just great that we have the Biome team because they've set up the ecosystem where we can meet these companies. We can then present what the problem is and what solutions we expect, and also assist in connecting them with the regulators in the countries where we have these programs, and also connect them with the specialists and the caregivers and the nurses and the doctors.
We could make progress faster by working with Novartis than we could working by ourselves, or even than they could maybe just working by themselves in a country like that. Because you can't do treatments without the diagnostics. And I think that's where the synergy can really happen.
So this video highlights so many of the things that actually I will try to emphasize and mention in the book. Being connected to the community and listening to the community leaders, working together, diagnostic companies, pharmaceutical companies, and the caregivers, patients, patient advocates, working all together in coming up with the solutions the most comprehensive and the most impactful solutions that you can come up with. So this is one example of how diagnostics and interventions can be developed together so that they can complement each other and make a real impact in the world. You know, for example, the Novartis Himex Health collaboration is ongoing, and in Ghana, most of the children with sickle cell disease, when they are born, are screened using Himex Health Gazelle HP variant test, and all the babies and the children who test positive for the disease receive low-cost, affordable treatment options from supported by Novartis and the government of Ghana. So this is a government-public partnership, a very good example of a government-public partnership to make these treatments available. So, but this is like I'm showing you with the video the outcome of all the years of research, many years of research that we have done here at CASE and also in the clinical environments worldwide. I would like to now go into the details of how we reached to this stage and what type of inclusive approaches we followed to reach to this stage. So, as I mentioned earlier, and also mentioned in the video, this diagnostic platform is now available in more than 40 countries, and hundreds of thousands of lives are touched every year by these tests. So, in other words, hundreds of thousands of babies are now being screened using these diagnostic devices that we developed here and translated and commercialized everywhere in many of these countries. And they receive the treatment, and they are in a path to a relatively normal life until much better treatment options and cures become available. So, this did not happen by coincidence. In every single country that you see in the map that is using the diagnostic device had a special emphasis in terms of research and clinical studies and the local interactions and the local regulatory requirements and so on. So we did significant activity in every single country, even during the development stage, to understand the local complexities and local needs, local perspectives better. And as you can see, Africa is huge. So many countries in Africa, but we actually did a lot of work in all of these countries, in addition to India and Southeast Asia, to make these, translation possible in multiple countries at the same time. So I would like to just briefly talk about the fundamentals of the disease and why such diagnostics and the treatments that I will talk about are important here. So in this context, we are talking about common red cell and hemoglobin disorders, which are inherited genetic disorders. And you might actually have, depending on your inheritance from your parents of these genes or mutations, you might be a carrier, you might be healthy, first of all, which is most people. You might be a carrier if you inherited this mutation from one of your parents, or you might actually have the disease in a homozygous way if you inherited from the mutations from both of your parents that would give you the disease. And there are also other mutations that result in other hemoglobin mutations. And if you look at all the combinations, you can actually get hundreds of combinations. So, for example, sickle cell disease, thalassemia, hemoglobin E, hemoglobin C, you can have hemoglobin SC disease, SE disease, S beta. So there are many combinations. So it is really important to keep this in mind, and also the geographic distribution of these different mutations that happen in different parts of Africa. For example, hemoglobin C is more common on the western side of Africa, western sub-Saharan Africa, and hemoglobin E and beta thalassemia is more common on the eastern side. So it is important to keep these geographic and genetic mutations and variations in different places. And some of the other technologies that we develop focus on hemoglobin properties, which is normally hydrophilic, highly soluble in water, and in the case of sickle, hemoglobin hydrophobic, and when deoxygenated. And we develop tests to measure these properties in relation to some other therapies. And if you focus on sickle cell disease and trait, this is quite painful and lethal. And in the world, it's estimated that this is probably an underestimate, but it is estimated that there are 300 million people living with the sickle cell trait and 30 million people living with the disease. And the world average of reduced lifespan due to this disease is more than 50 years. So this, if you have this disease, your lifespan would be reduced by about 50 years and more. And in US and Europe, due to the nationwide screening programs and treatments that are available and you know, a better healthcare system in terms of treating the people who are diagnosed with this disease, the lifespan is reduced, but still significantly lower than healthy individuals. So a 30-year reduction is still the average in these parts of the world. And it's estimated that there are 6 million people with the trait and 200,000 people with the disease. This is also probably underestimate. And the prevalence of the disease is expected to increase more than 30% by 2050. And geographic distribution, I keep showing you these world maps because it's important to note that these genetic mutations, these inherited disorders are more prevalent in certain parts of the world, sub-Saharan Africa, mid portion of Africa, India, South America, and also the Middle East. So hemoglobin disorders and anemia, which have ties, interesting ties, which I don't really have the time to go and talk about those, common in the certain in the same regions of the world, which associate with the low and middle income countries and many of the health, you know, resource limited settings of the world. So the solutions that you create for these problems should keep that in mind, the geographic distribution and the resources that are available there. So one quick note, a recent development, since these are genetic disorders, it is possible to cure them with the new gene-based, cell-based therapies, CRISPR-based, for example, gene editing therapies can be used to cure them. And very recently, a company called Bluebird Bio received FDA approval a few months ago for a gene-based cell therapy to cure beta thalassemia, transfusion-dependent beta thalassemia, which is a very severe form of hemoglobin disorder, somewhat similar to sickle cell disease, but it's much more severe if you inherit mutation from both of your parents. And this drug became the most expensive medicine in history with a 2.8 million price tag. It's a one-time treatment, and you are cured if the treatment is successful, but it costs $2.8 million. And the company behind this medicine, this gene therapy, they argue that the price of its one-off treatment is just a fraction of the lifelong costs of ongoing healthcare, because these patients are dependent on regular blood transfusions to live. So this is a recent development, but the 2.8 million price tag for a disease that primarily impacts people who are associated with low-income populations or resource-limited regions has created some controversy, and in the recent months. And the question is, you know, does this really make sense? Like curing a disease with this type of a price tag? Who is going to afford it? Will all the patients be able to afford this? And it is important to keep in mind that more than 90% of the people living with this disease live in Africa and India and Middle East, in the low and middle income regions there. So having a 2.8 million price tag here in the United States or Europe has certain implications for the patients in those regions. The interesting thing is none of these regions, none of these countries or patients have been involved in the development and the clinical trial of this therapy. All the patients and all the trials happened in Europe and the United States, which I will talk about briefly. So this is the map. All the resource-limited settings are currently excluded from cell and gene therapy development, mainly due to the lack of infrastructure. And you can actually see that the crosses are the countries with current gene therapy trials in progress. And the blue regions, blue color indicates low-income countries, and there is not a single cell or gene therapy trial that is taking place in those regions. Recognizing this shortcoming and thinking about, what we can do about this, we got together with a group of scientists, researchers, patient advocates, non-profit organization leaders. A large group has come together and created the Global Gene Therapy Initiative to understand the shortcomings, limitations, challenges associated with not having any of these trials in those regions and doing something about it. And our goal is to have a cell and gene therapy trial in Africa and India by 2024. And our role as Case Western Reserve University and my lab specifically is to support the initiative in terms of diagnostic needs, developing the diagnostic infrastructure so that these therapies can be possible. And the School of Medicine is also working on the place of care manufacturing of cell and gene therapy products for these trials. So this is an important message from the discussion that I just had so far. I think that if you are going to a resource-limited region to do a clinical study or product development or technology development or validation, your intent should not be just to go there with and thinking that you will be helping the local communities or the patients. That's not sufficient. We should have the intention to go there and do this together, learn together, and address these problems together. And eventually, the solutions that we create, we should keep in mind that those solutions will also benefit the issues, the challenges that we have in the healthcare systems of the Western world or the more resource-rich regions. So this is something that I always remind myself, this quote, and also my students whenever we go to go do studies in those regions. So here is our approach in a quick summary manner of how we can actually make, for example, personalized medicine approach a reality in sickle cell disease. Sickle cell disease is the next frontier when it comes to cell and gene therapies, and probably will have the biggest impact once these therapies become available. But we should recognize that, as was also mentioned in the video, we have to think comprehensively. First of all, we need to develop the screening programs. It's important to note that more than 90% of the babies who are born with sickle cell disease still don't have access to screening programs in Africa and India. So we have to first make sure that every baby who is born with with these diseases have access to proper screening and diagnosis, so that their condition can be recognized early. So we are actually working on developing screening programs in Africa and India, supported by the technologies that we have developed, so that these people would be recognized early on, so that they can be a part of the healthcare system and start receiving the treatments. So hopefully in the next 5 to 10 years, 15 years, when the gene therapies become feasible and available, they will be around, they will be alive to benefit from those therapies. Diagnostic is not enough. We also need treatments. That's why we have to work with pharmaceutical companies and convince them that and show them that affordable diagnostics is not sufficient to solve the problem. These patients also need to have access to affordable treatments. Hydroxyurea, which is a generic drug, is now, for example, provided at very low cost, at high quality manner in coordination with the local governments in Africa. Ghana was the first country to do that, and now it is happening also in other places. The same concepts of pairing diagnostics with affordable treatments is also an important consideration for the US healthcare system, because some of the more advanced drugs, for example, oxbryta, voxelotor, or crizanlizumab, they are very expensive treatments that are available in the United States, but their accessibility is still a question. So there are similar challenges in terms of access to diagnostics and treatments in the United States versus in Africa, for example, but the scale is different. For example, $100 therapy might be cost prohibitive in Africa, but $100,000 treatment might be cost prohibitive in the United States, even maybe lower amounts. So coming up with solutions in Africa at smaller scale cost amounts have also implications on coming up with solutions in the other healthcare systems that deal with larger numbers but similar issues. I will not have time to talk about all those different intricacies of these things that I mentioned, but if you have questions, we can maybe focus on those. And also the biggest potential for curing such diseases and essentially realizing the ultimate personalized or precision therapy is gene therapy. And even in the United States, the cost is million plus, as I gave you an example, 2.8 million for beta thalassemia. And probably when we have the first gene therapy available for sickle cell disease, it will have a similar price tag, $1 million or more. And our approach is a diagnostic technology development group here at Case Western Reserve University. We want to create a diagnostic platform so that, for example, the hydroxyurea implementation programs in Africa and India become feasible, supported by affordable diagnostics and monitoring approaches. Similarly, therapy development in the United States for these more advanced therapies become reality and more inclusive of sickle cell disease patients across the country as well as in Africa and India. Imagine, for example, if one of these countries, Novartis or GBT or Forma, if they can perform a clinical trial in Africa, then it will change, it will expose them to the realities of Africa and realities of the clinical care in those regions. And maybe their perspective will change. Maybe they will come up with a different treatment or different delivery modality. So our work on the diagnostic side helps them perform those trials in Africa and India. So we would like to convince them that we can provide them the technology that they need so that they can perform such trials and studies in Africa. So we work together again with the pharmaceutical companies to make this a reality. For example, in the case of lower cost, more accessible treatment options, we have developed the company Himex Health to support the screening and also monitoring of these more accessible therapies. In the context of more advanced therapies, we have started a company here in Cleveland, Ohio, which does not have FDA-regulated products in the market yet, but it provides support structure for the clinical studies and clinical trials for these companies that develop new pharmaceutical approaches here in the United States. And for example, a few weeks ago, I was in Africa visiting Uganda. We would like to start a similar lab in Uganda so that companies can also use the diagnostic infrastructure that we create to start trials, clinical studies and trials in Africa. So there are no clinical trials in any of these diseases right now, in any of these treatment modalities right now in Africa. And our bigger vision is to make the companion diagnostics also a reality for these more advanced therapies, again, so that these companies can go to Africa and perform clinical studies and clinical trials in Africa. And in doing this, we follow an inclusive and equitable translational pathway. Maybe I can just quickly summarize this here with this slide. So our approach is to engage the customers, the regulatory bodies, pharmaceutical companies, the market needs, reimbursement experts, IP, as early as possible in our invention and development process. So we don't invent just because it sounds good, or it's a new idea, or it's a new technology that sounds cool to engineers, for example. We follow a need-centric, problem-oriented invention and translation approach that is informed, disciplined, and bottom-up. Starts with, for example, with interviews with the customers, all the stakeholders who would benefit from these pharmaceutical companies, local lab directors, nurses, caregivers, patients, and we start from there. And then when it is time to invent and prototype, we engage with FDA experts and WHO, World Health Organization, was mentioned many times in the book, as you may remember. So we engage with those experts to make sure that the solutions that we come up with can receive regulatory approval down the line. And we keep the preclinical studies as short as possible and focus on high intensity, extensive clinical studies in relevant parts of the world, again, in a really community engaged way, so that we can receive the best and the most relevant information needed to perform the studies and the trials. And engaging the local regulatory experts, local engineers, customers meaning whoever is going to use the technology that you develop, it's very important. And this approach helped us minimize the need for funds raised, and also minimize the time to market, and also made translation and commercialization in those regions a possibility. I have some examples of how we do these things. Maybe I will just skip these things and refer back to them if we have questions. Many of the things that I talked about today were actually published and presented in a recent article that was expertly authored by our CTSC colleagues, Kelly, Shannon, Clara, and I think there was a presentation last week that mentioned this article. So more information can be found here. And I will stop here for the Q&A and follow-up discussions. Thank you very much.
Okay, thank you, Dr. Gurkan. Please type your questions in the chat and take yourself off mute, please.
Dr. Gurkan, are there any talks at the policy level to try and reduce some of those costs for those technologies that are so expensive right now?
Yeah, so there are many talks, and the Global Gene Therapy Initiative that I mentioned is really focused on, figuring out what can be done to reduce the costs. But our approach is, if these companies and if these researchers, if you look at the cell and gene therapy researchers, they are focused on in a few institutes in the United States or in Europe. And these are like the top research institutes, state-of-the-art facilities located around Boston, San Francisco areas on the coasts primarily, and maybe Pennsylvania, Philadelphia, and they just need to go and figure out how they can perform these clinical studies and trials in the real world setting, not just in the comfort of their high resource environments and clinics and facilities. But if these therapies are going to benefit the patients who live in the real world, and these trials have to run in the real world setting, the companies have to realize that if they don't go to Africa, they will never be able to figure out what it would take to reduce the cost of these studies, cost of these therapies. So our approach is actually not to convince them that they should just take what they have already developed and reduce the cost. We think that a new way of thinking is needed here. You cannot just, try to reduce the cost of a 2.8 million therapy that has already been approved and that already works in the facilities that they have been tested, for example. We need to create new approaches, new therapies, new diagnostics. And it all starts from bottom up, going to the actual setting, talking to the patients, talking to the real customers, users, and start from scratch. So a top-down approach where you take what has already been approved, what is already costly, and try to reduce the cost would not work. We have to do the bottom up for new therapies and new diagnostics. So that has been our approach. Bring the trials and studies and research closer to the actual environments, actual people, the real users and the real patients, so that we can come up with new approaches that will hopefully be much more cost effective.
Do we have any more questions for Dr. Gurkan? Okay. Thank you, Dr. Gurkan, for your presentation. And we'll move on to some questions that we have. Some questions that we have that Jaleese has presented us for slides. Okay, so how would you apply this framework to your work?
Is this a question for me or for
Yes.
the?
You can answer, Dr. Well, yeah, it's actually for the audience, but
Yes.
Anyone?
yeah.
So framework meaning here, probably global and local communities working together to solve the problems, to help the world, right? So yes, that's a good question.
Okay. All right, we got a couple of definitions I want to read.
Mm-hmm.
Solutions created and resource poor contexts also have the potential to improve care in resource-rich settings. The best way to facilitate new partnerships is through a known member within the community.
So that known member in the community has been key, for example, in our case. In every country that we went in to do the first initial clinical validation, clinical studies of a new technology, you need to work like known member, meaning known to the local community, and also in our case, we wanted those members to be known in the the international community as well, so that we can, for example, go and work with someone who is known in the international hematology community as well as in the local community, so that if the study is successful and if we get good results, you will have an additional boost from the credibility of the person that you are working with. And that also brings another aspect. So those known members of the community are probably known because of something, because of something that they have done. Maybe they have done an impactful work in the local community. Maybe they did an amazing research. Maybe they have publications, or maybe they changed the current practice. So they will have a strong network of connections and knowledge and know-how and experience that you can benefit from. So this is such a key point here that was made in the book, in the chapter 6 of the book. So, for example, in some countries, we performed clinical studies and we had hard time publishing the results. And when I was talking with some leaders in our field, I asked them, we did this amazing clinical study here, and we are now having hard time publishing it. And the answer, and I asked him, why do you think this is happening? And he said, you probably didn't work with the right person or the right group in that specific clinical study. So identifying those local and international leaders who can really contribute and help and advocate in certain cases for your work together with you is quite important.
Okay.
So the previous comment was quite important. Solutions that are developed in resource-poor context. I think in cell and gene therapy is a very good example of that. If we keep developing the next generation cures for many of these diseases, cancer, infectious diseases, inherited diseases, if we keep developing them in the most resource-intensive settings of the East Coast, West Coast research institutes, they will never be cost-effective or benefit as many people as they need to benefit. So they will always be expensive, resource-intensive, expertise-intensive, technology-intensive. Unless these clinical studies and research and development happens in resource-limited settings, or in close collaboration with researchers and investigators who operate in those settings, they will never be low cost. So this is our approach. This is the reason why we started the Global Gene Therapy Initiative, to at least have a few studies and trials that take place in those regions so that people will start realizing the realities and the unique needs of those environments. So that's why solutions that are developed in resource-poor context will also have a significant impact to improve healthcare and access to care in resource-rich settings. Solutions that are developed in resource-rich settings are even too expensive for the settings that they are developed in many cases.
Oh. Arlette, you had a question?
I did. I kept thinking your presentation was really good. Thank you. And I also want to state that it is very weighted or heavy, because the reason why I wanted to be a part of the book discussion was because it is everyone's problem. But it is hard to get people to see beyond, and I'm going to call it out, beyond race, because I actually believe you may be working with the right partners. But if the partners don't see the buy-in, whether that's green for money, then what is the incentive for them to even want to go to these regional areas? And that becomes the partnership. If they can't see the green in it for these major pharmaceutical companies or investments, then it becomes, why should we do it? And so you did a really good presentation. You may be working with the right partners, but then the question is, and I guess to the panel, to everyone else too, is how do you spin it so that they see the value in it, even if the value is about green money?
It is a very good question, and this is something that we struggle with regularly on a daily basis. Reducing the cost, making something cost effective, oftentimes comes with limited commercial viability, or these companies will have to, they may think that they will probably make less money if they sell the product at a lower cost, right? But in the context of sickle cell disease, I mean, there are many different examples that we can discuss, but in the context of sickle cell disease, one silver lining is 99% of the people who live with sickle cell disease live in resource limited settings. So for example, a gene therapy that is $1 million, that costs $1 million, it might actually, if it is, for example, intended for the US market or European market, that's 1% of the, less than 1% of the all the patients that are available in the world. So if a financial model can be made such that instead of developing a costly approach for 1% of the patients, if you develop a lower cost approach that benefits closer to 100% of the patients, maybe you can make more money overall. So there has to be a commercial, you cannot just, approach these issues thinking that, there should not be any commercial or economic or financial incentive. There has to be. These companies still have to exist. They have to be sustainable. They have to make a lot of money, unfortunately, in the context of pharmaceutical companies, especially. And it is, I think, sometimes as an engineer, I feel like it is our job to figure out what would convince them to see that there might be a financial benefit to reducing the cost, so that they will be able to access more patients, for example. I think, for example, why Novartis is doing this in Africa is they realize this. And when they have therapies available in the next 15 to 20 years, if they keep the patients alive as long as 15, 20 years, they will have more customers in the future. So this might be their thinking, unfortunately, but this is an important consideration. We cannot ignore the fact that they are financially, motivated in many cases, these companies. I hope this answers your question, but it's very complex.
Okay,
I was gonna add just a quick comment. Dr. Gurkan, I remember when we were putting the paper together, the JCTS paper, one of the comments that you had brought up and we had asked was, to this point, I think you said that finding someone who kind of had a heart for the disease or the piece that was being studied kind of went a long way.
Yes.
Trying to, you almost have to have a heart in it a little bit,
Yes.
as well as the money, that helps. But really trying to find that right fit for those investors, just because it seems like when you have a heart in it, maybe you're going to go a little bit more out of your way to make sure it goes through and happens.
Such an important comment. My previous answer was maybe too much, focused on the financials, but yes, there is that aspect, there is that human aspect. If you can actually find someone who has some connection to the disease or the population that you are working in or the country. For example, in the video that I showed you, there were two really nice people from Novartis who are in the upper leadership of Novartis. Patrick, one of them is Patrick, who is a really good friend, and he's originally from Ghana, but works for Novartis now. And his influence in the company was quite important for us to be able to engage with this really large global company. Sometimes a few people in those organizations who have the heart for the disease or the country or the population might make a big difference. In the case of investment firms, when you are trying to raise money for these type of initiatives, if you can find an investor who has, again, some emotional or some personal connection, that goes a long way. For example, one of our most important investors was someone who was born in India and grew up in Nigeria, and then moved to United States for college, and then became quite wealthy here, started companies, sold them, and he had a connection to Nigeria and India. And these two countries were the first two places that we did our clinical studies in, because of other reasons, because the disease is highly prevalent in those regions. And also, also because we had an investor, for example, from who had connections to those places. So these things make a very big difference. I agree with you, and thank you for bringing this up. There has to be financial incentives. There has to be connections. All the things that you can leverage, to make these type of studies a possibility is, fair game. I think you can find such investors. You can find people in the companies who would like to do something about sickle cell disease, for example, or do something in Africa. Other companies that I listed in my presentation are also interested in doing clinical studies in Africa. And most of the time our contacts in those companies who are interested in such studies are the people who have some connection to the disease or to Africa, people from Africa or India, for example, who are working at the company. They can use their position and their personal connection to make a really good case for example, exploring such opportunities. That's very important. Yes, very good point.
Okay, do we have any more questions for Dr. Gurkan? Okay,
Maybe I can ask a quick question to the whole panel since we have a few minutes. So what was in the chapter 6 of the book, what stood out for you? What was if you can just tell me one thing that stuck to your mind, that you remember from chapter 6, what was that? Any comments? Anything that you related to in chapter 6 in terms of the global health aspects?
I was I was just going to say that a lot of what goes on in Africa, I am definitely, I don't say definitely, but I am somewhat aware. And so what chapter 6 for me, it just reinforced stuff that I knew, and the hardship of that regional, though that continent, but definitely the regional area like Ghana. And so I believe, because I like what you said about you have to have the heart, and so it's not just money, but it's a combination of both. So every dollar helps, but
Yes.
also what goes on over there is it's heartbreaking. And it's overwhelming. And it's like you just said, it's a big problem. It's not just you can just go over there and just throw money at it. You have to actually be in the community to make a difference and to find out how to navigate the continent and the country in itself.
Exactly. Every country is different.
Yes.
Every group of people is different. North part of the country is different than the south part of the country in many different places, different tribes, communities. But you have to understand all these different dynamics and how to engage and how to present these new ideas to them carefully. But the more importantly, wherever you go, you learn something new. You should just be open to these new learnings and incorporate them into your day-to-day thinking. That's the key. Sometimes I go to sometimes, for example, when I visit Africa and different parts of Africa, I just go to certain clinics where our technologies are used without any agenda. I just show up, talk to people, and be open to surprises. Sometimes they tell you, this aspect of the technology sucks. Sometimes they don't even know you as the inventor or the developer, or they give you some so amazing ideas. I actually had a video in which users gave us such an amazing idea because they were already testing using the technology for a different purpose, which made so much sense. But you realize it when you talk to the people in the field who are living this day to day. We live this day to day on the research side, but they live these diseases, they live these treatments of these diseases and experience with the patients on a day to day with a different perspective. And having access to those ideas, perspectives, experiences is such a unique and important part of our research. So that's why this type of research has to be connected, has to be inclusive. These pharmaceutical companies should go spend time there, talk with the work with the local experts, and maybe someone from Ghana or Uganda will come up with an idea that will make this therapies like cost 10 times less or maybe 100 times less. But I don't think that cost conscious, resource conscious ideas will come from people who are not exposed to those environments and those realities.
Okay, thank you
Thank you.
again. Thank you again, Dr. Gurkan, for your presentation and facilitation. We're grateful that all of you decided to join us for week 7 of the challenge number 2 in our mission, Health Equity Challenge Series. We'll look forward to seeing you for our final meeting on Thursday, December 1st at noon. We hear presentations from Drs. David Kilber and Dr. Pam Davis. Thank you again and have a great afternoon.
Thanks, everyone.
Thank you.
Thank you, Dr. Gurkan.
Bye.
Bye-bye.